Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. NIK NIKAM, and this is Cardiology Lecture Series. And all our programs are video streamed through YouTube. And please do subscribe to our YouTube channel. Now, the feature presentation. Hello, ladies and gentlemen. I am Dr. NIKAM, and welcome to ACLS lecture series. In this presentation, we are going to focus on post-CPR algorithm. After having successfully treated a patient with a cardiac arrest and spending 45 minutes getting this patient out of ventricular tachycardia, fibrillation and asystole, you have been successful in getting this patient into a sinus rhythm. Congratulations. We have just transferred the patient to the intensive care unit. The role of the ACLS team or the rapid response team is just beginning to end, but this is not the end as far as the patient is concerned. This is just the beginning of a new phase for the patient. As soon as the patient comes into the intensive care unit, the most aggressive treatment that was applied during cardiopulmonary resuscitation needs to be continued, and the new team, as they take over, they need to be focusing on many different areas in terms of administering treatment, diagnosis and management. So let's look at some of these things that are going to make a difference as to life versus death following cardiac resuscitation. If you understand that only 25% of the cardiac arrests are successfully resuscitated in a hospital environment, and in an out of hospital environment the success rate is only between 10 and 11%, you understand the magnitude of the responsibility that is relying on people who are managing these patients in the immediate post CPR care. Once this patient is transferred to the intensive care unit, we need to focus on airways. Make sure that the patient is intubated if it's feasible, maintained on adequate oxygenation to keep the oxygen saturation level about 94%. And also monitor blood gases to look at the pH, because as you know, if the patient has been hypoxic for a long time, there could be lactic acidosis, respiratory acidosis. So we need to monitor all these things with a blood gas. So monitor the pH, the PO2, PCO2 and the bicarb, so we can adequately adjust our treatments based on those. And capnography is a must for all post-cardiac arrest patients. This will tell us how well the body is able to produce carbon dioxide and, more importantly, transport this carbon dioxide from all different areas of the body through the lungs and adequately exchange this carbon dioxide for oxygen. The normal level of carbon dioxide should be 30 to 40 millimeters of mercury, and that is a good indication of the entire pulmonary circulation. And the oxygen saturation, especially in the capillary beds in the fingertips, is a very good indication of how good the cardiac output is and how good the peripheral perfusion is. So all these things are important. In order to maintain peripheral perfusion, we need to have adequate blood pressure. If the blood pressure is low because of volume, because of bleeding, because of shock, because of septicemia, all these things need to be addressed. Vasopressors are good, but vasopressors should be given in the context of volume correction and blood correction. And we also need to look at any evidence of sepsis that might have caused profound vasodilatation, which needs to be treated with perhaps aggressive antibiotics and also steroids if necessary. The third element that we need to focus upon is the cardiac rhythm. Cardiac rhythm can be a nagging problem in a patient in a post-CPR state. They can have atrial fibrillation with rapid ventricular response like 160, 180, which increases cardiac work, which increases cardiac oxygen consumption. which decreases the venous filling pressure. As a result, the cardiac output is dramatically reduced. So controlling rate is of great importance in patients with tachyarrhythmia, especially following a CPR in the presence of an ischemic heart disease or patients who are hypoxics. So we would do everything using calcium channel blockers, beta blockers, digoxin, amiodarone, whatever it takes to bring the ventricular rate to between 60 to 90 so that we maintain optimal cardiac output for better tissue perfusion. And when patients are coming out of cardiac arrest, invariably they have significant myocardial ischemia, and that can produce ventricular arrhythmias or PVCs, bigeminy or trigeminy, and hence these patients need to be continued on antiarrhythmics that were used during the cardiopulmonary resuscitation. Once we have taken care of these basic elements of airway, perfusion, rhythm control, the next thing is to look at the 12-lead electrocardiogram and see, do we see an identifiable cause that needs immediate attention? Yes, indeed, I am talking about STEMI or non-STEMI. If we have a patient with the STEMI, that patient needs to be going to the cardiac catheterization lab even while the CPR is in progress. The patient needs to get into the cath lab, and immediately we need to visualize the coronary arteries, improve the perfusion by putting a balloon or a stent, thus salvaging the myocardium, reducing the myocardial ischemia, and hopefully minimizing the risk following a massive myocardial infarction. Once the patient's condition is stabilized, we can treat them with antiplatelet agents, Plavix, aspirin, statin, and of course we need to control the risk factors such as diabetes, hypertension, smoking, and all the other things. If the patient has a non-STEMI, but still non-STEMI is also important because these patients also may have critical coronary artery disease because they have abnormal EKGs and possibly elevated cardiac enzymes, and they need to be very closely monitored. If there is any worsening of symptoms or changes in the electrocardiogram, these patients need to go to the cardiac catheterization lab, and they need to be evaluated for any critical coronary artery stenosis, which can be treated with balloon and coronary stents. Again, they need to also be followed for management of risk factors and minimizing the subsequent cardiac events. We have to understand patients with the non-STEMI have a 30% chance of getting a recurrent attack within the first 3 months. Hence, it is very important to see if there are minimal changes and the enzymes are very borderline. We can in fact further evaluate these patients by provoking myocardial ischemia in a nuclear stress lab, and if there is evidence of reversible ischemia, then these patients should go for cardiac catheterization, all the subsequent treatments just like the STEMI patients undergo. If this is not a cardiac event, the next thing is we come down the line and evaluate the patient for the possibility of a pulmonary embolus, trauma, bleeding, or stroke. And based on these things, all the different managements are going to be sort of tailor-made to that particular condition. And there are times when patient's condition is not very stable, then even we can consider hypothermia to minimize the oxygen need for the entire body. So there's a lot of work that needs to be done right after resuscitating a person from a cardiac arrest and getting them into a sinus rhythm. And that is just the beginning. The second phase is more complex. It involves multi-system and multiple specialists, and time is of the essence in most cases like STEMI, stroke, or bleeding. So, ladies and gentlemen, this is in a nutshell post-cardiac care algorithm, just to give you an overview as to how important it is to understand the significance of time in implementing proper interventions to minimize the damage and maximize the overall condition of the patient. Thank you so much for watching. I am Dr. NIK NIKAM. Thank you so much for watching our program, and please do subscribe to our YouTube channel. If you would like to support this program, you can look for the $ on the right hand side of your browser and support in any way you possibly can. Again, thank you so much for watching this presentation, and until next time, I am Dr. NIK NIKAM.